Welcome everyone. C'est vraiment un plaisir de vous accueillir dans ce beau cadre d'Alex Trebek à l'Université d'Ottawa ce matin. C'est une salle peut-être un petit peu difficile à trouver. Donc, les autres personnes vont pouvoir nous rejoindre, mais nous devons commencer pour pouvoir accélérer la journée et surtout respecter le programme. Welcome everyone. It is a pleasure to welcome you today in this framework, Alex Trebek. And we are going to start. We know it is a difficult place a place difficult. Usually we have difficulty to find, but it is important to start now to respect the program. I have the pleasure this morning to introduce Dr. Martine Lagacé. She's the Vice President Research and Innovation here at the University, Vice President Associate Research and Innovation here at the University of Ottawa. She's a great supporter of the Interdisciplinary Center for Black Health, and it is really a pleasure to introduce her this morning. Dr. Martine Lagacé.
Merci beaucoup, Professeur Cénat. Chers collègues, bonjour à toutes, bonjour à tous. Greetings to all our distinguished guests, colleagues, students, and to all participants. Comme il a été mentionné précédemment, my name is Martine Lagacé. I'm the Associate Vice President, Research, Development, and Promotion at the University of Ottawa. And on behalf of our Vice President, Research and Innovation, Dr. Sylvain Charbonneau, it is my great pleasure to welcome you all on our campus today to kick off the second edition of the symposium organized by the Interdisciplinary Center for Black Health on the topic of vaccine hesitancy and health equity in racialized communities. As is customary, I would open this session by paying respect to the Algonquin people, who are the traditional guardians of the land where the University of Ottawa is located. We acknowledge their long-standing relationship with this territory, which remains unceded. Nous rendons également hommage à toutes les personnes autochtones qui habitent Ottawa, qu'elles soient de la région ou d'ailleurs au Canada. Nous reconnaissons les gardiennes et les gardiens des savoirs traditionnels de tous âges. Nous honorons aussi leurs dirigeantes et dirigeants d'hier, d'aujourd'hui et de demain au courage indéniable. J'aimerais ce matin saluer chaleureusement M. Nicolas Gilbert de l'Agence de la santé publique du Canada. Notre collègue, le Dr Peter Liu, qui n'est peut-être pas encore arrivé, mais qui se joindra plus tard aujourd'hui. Dr Liu est directeur scientifique et vice-président de la recherche à l'Institut de cardiologie de l'Université d'Ottawa. Et les membres de la communauté de recherche des universités de Wisconsin-Madison, de Toronto, de Calgary, de Laval, de Waterloo et bien sûr de l'Université d'Ottawa. J'en discutais avec Jude un peu plus tôt. C'est un symposium de haute voltige avec des gens de plusieurs institutions, donc ils vont partager aujourd'hui leur savoir sur cette question importante et d'actualité certainement, et envisager des solutions, des pistes d'action, des pistes de solutions. Je salue également les nombreux représentants de Santé Canada qui interviendront durant ce symposium. True to its mission and under the leadership of Professor Jude Mary Cénat, the Interdisciplinary Center for Black Health continues to advance research, to mobilize knowledge, and to inform public policy around racial health disparities. It does so with a view to help bridge the gaps in care for Black communities, also reaching out and expanding knowledge to diverse, racialized, and Indigenous communities. This conference is precisely an opportunity to take stock of the outcomes generated by the studies and initiatives undertaken to better understand vaccine hesitancy and uptake within those communities. Les thématiques des différentes présentations de ce symposium témoignent de la réussite du Centre à créer des synergies de recherche indispensables pour favoriser une approche multidisciplinaire, multicommunautaire et concertée pour faire face aux problématiques d'hésitation vaccinale des communautés raciales, ethniques et migrantes. Providing stakeholders with the knowledge to strategically engage with those groups to facilitate their access to, as well as their trust in health services, is central to achieving health equity in Canada. I would like to seize this opportunity once again, and I always do so, to congratulate Professor Jude Mary Cénat and his team. not only for their leadership in our academic community, but also for their commitment to mobilizing knowledge among government decision makers, NGOs, leaders of Canada's Black, racialized, and Aboriginal communities, for contributing to advance health equity for these communities. Le Centre joue un rôle central à l'Université d'Ottawa et notre cabinet continuera de vous appuyer et c'est personnellement un engagement important de ma part. Nous sommes fiers que le Centre interdisciplinaire sur la santé des Noirs ait un impact grandissant en matière d'équité et de sensibilisation dans le domaine de la santé des communautés racisées, contribuant ainsi à faire rayonner l'excellence et l'impact des activités de recherche de l'Université d'Ottawa. Je vous souhaite des discussions fructueuses aujourd'hui, des échanges productifs au plan intellectuel, des pistes d'action, j'espère, qui s'ouvriront. Bien malgré moi, je ne peux rester avec vous en raison d'un autre engagement professionnel. Mais je vous remercie encore une fois, vous tous et toutes, d'être là aujourd'hui. And I wish you a very, very fruitful event. Thank you very much.
It is now my pleasure to introduce Monsieur Nicolas Gilbert from the PHAC.
Bonjour. Hi everyone. La pandémie de COVID-19 est derrière nous, mais nous vivons encore aujourd'hui dans un monde profondément transformé par elle. Par exemple, 2 ans de confinement ont profondément modifié nos interactions avec les autres. Notre réponse à la pandémie a entraîné des progrès rapides dans certains domaines. On l'a tous constaté, plusieurs employeurs ont rapidement amélioré leur réseau informatique et adopté des technologies afin de faciliter le travail à distance, au point que même après la fin du confinement, leurs employés ne sont jamais revenus à temps plein au bureau. Il y a aussi eu des progrès marqués en santé publique. En premier lieu, le développement rapide des vaccins ARN messagers de Pfizer et Moderna qui ont grandement contribué au contrôle de la pandémie. Plusieurs provinces canadiennes qui n'avaient pas de système d'information permettant de suivre la vaccination en ont adopté rapidement, ce qui a permis à tous les niveaux de gouvernement de suivre de semaine en semaine les progrès de la campagne de vaccination. Et on a pu constater qu'on a vacciné 80% de la population canadienne en moins d'1 an. Il y a eu aussi des changements moins positifs. La désinformation en santé a toujours existé, mais nous avons assisté pendant la pandémie à des campagnes de désinformation d'une ampleur et d'une intensité jamais vues. Était-ce vraiment nouveau ou seulement plus visible? Je n'ai pas la réponse à cette question. Mais je vois dans le programme de cette journée que des experts de la question viendront nous éclairer sur cette question. Et il y a ce qui n'a pas changé, malheureusement, les inégalités. Dès les premiers mois de la pandémie, on a constaté que certaines communautés, dont les communautés racisées, la communauté noire, entre autres, étaient plus durement touchées par la COVID-19. Et lorsque la vaccination s'est mise en branle, nous avons constaté que là encore, certaines communautés avaient été moins bien rejointes que d'autres. Les données de surveillance et les enquêtes nationales menées par l'Agence de la santé publique du Canada nous permettent de constater les inégalités, mais pas de les expliquer, ni d'y trouver des solutions. Pour progresser dans ces domaines, il faut travailler avec les communautés elles-mêmes et avec des groupes de recherche qui y sont bien implantés. C'est pourquoi l'Agence est fière d'appuyer le Centre interdisciplinaire de la santé des Noirs et d'autres partenaires dont les travaux ont déjà apporté et continuent de nous apporter un nouvel éclairage sur l'hésitation à la vaccination dans les populations racisées. Nous en entendrons davantage à ce sujet aujourd'hui. Au nom de notre directrice Julie Laroche, qui malheureusement n'a pas pu être présente aujourd'hui, je remercie le Dr Cénat et son équipe d'avoir organisé cet événement et souhaite à toutes et à tous un excellent colloque. Merci.
Merci, M. Gilbert. I want to maybe say some words in terms of context before we start. 2 weeks ago, I had a call from a mother, a black mother, saying, I want to vaccinate my newborn, but my husband doesn't want. So for my husband said, we will not vaccinate our kid. And I had a discussion with her, and then we had a discussion in the center about that. And it was not the first time researchers from the center were called by Black people to express their concerns about vaccination. And 1 week ago, I spoke with to my colleague, my Indigenous colleague, and she told me it is exactly the same thing in our communities. Racialized communities are facing something that is very important, which is the non-vaccination of the kids. And I think it is not just racialized communities, it is also white communities. And I think we have to talk about it. This is why we try to have the most important researchers in that area in Canada. And I'm really happy to have you today to talk about that. And if you are here, it is because your work speaks for you. So I think it is an important event, and I'm interested by the discussion we will have. J'ai hâte d'avoir cette discussion avec vous, et je serai content d'apprendre davantage, because in the International Center for Black Health, we know for us it will not be just a project and that's it. We know we will have to work on that during the next 5 years at least. So thank you for being here, and I appreciate your presence, and let's have a great discussion. Et je vous souhaite une belle journée, et je vais faire appel à mon collègue, Dr. Idrissa Beogo, qui va être notre modérateur pour la première session. Thank you, everyone.
Merci, Dr. Cénat. Bonjour tout le monde, and welcome again to this conference on the vaccine in racialized community and indigenous community. My name is Idrissa, and I'm assistant professor in the School of Nursing in uOttawa here. C'est avec beaucoup de plaisir que je vais modérer la première session. Et voilà comment est-ce qu'on l'organisera au cours des prochaines 60 minutes. Dans un premier temps, les présentateurs vont présenter leurs résultats, et puis suivra la discussion de panel. For that, the first talk will be done by Dr. Vang, and it will be on COVID-19 experience and vaccine status and attitude among immigrant and racial ethnic minority in Canada. Dr. Vang is from the University of Wisconsin, Madison, and she is the Meta Schroeder Brickner Outreach Professor and Professor of Civil Society and Community Studies in the School of Human Ecology at that university, Wisconsin, Madison. She's also an integrated specialist in the ecology of healthy community with the Division of Extension Health and Wellbeing Institute. Dr. Vang was also a Williamson Dawson Scholar and Associate Professor of Sociology of McGill, I guess in Quebec, right? Okay. And she remained an investigator of the Research Institute of the McGill University Health Center. And in collaboration with colleagues at Statistics Canada and McGill University, she has published on COVID-19 and the healthy immigrant effect that she wants to share with us today. Dr. Wang, you are welcome.
This morning, what I'm going to do is summarize a little bit of what we know about vaccine hesitancy more generally, and then specifically talk about some of our findings on COVID-19 vaccine hesitancy. I will then briefly touch on COVID-19 vaccine hesitancy among immigrants, and then present some findings from a current study that my colleagues at McGill University and I are doing, sharing some of the results of that, and then finally ending with the summary of our findings. So what do we know about vaccine hesitancy? Well, first, by vaccine hesitancy, here I mean a delay in acceptance or an outright refusal of vaccination. Okay. Now, when we look at the literature, we see that the standard account of vaccine hesitancy tends to blame inadequate or incorrect information for resistance to immunization. This so-called knowledge deficit framework has been used to explain general vaccine hesitancy as well as parents' hesitancy when it comes to the vaccination of their children. Recent research, however, doesn't really support this knowledge deficit framework. And many information-based interventions to reduce vaccine hesitancy has proven largely unsuccessful or even counterproductive. A recent 2018 survey of 24 countries, including Canada, found that 3 of the 4 main causes of vaccine hesitancy were actually manifestations of mistrust, not necessarily misinformation. So what are those 3 components of mistrust? Well, belief in conspiracy theories, fear of curtailing personal freedom, and a resistance to the idea of social control over individual behavior. So that's what we know kind of very generally about vaccine hesitancy. Okay. What do we know about COVID-19 vaccine hesitancy? Well, the literature on this is just emerging. And what I have here on this slide are 3 studies published by my team at McGill. The project was a pilot study funded by McGill University and led by my colleague, principal investigator Ian Gold. So the data from the 3 studies are based on an environics survey of a representative sample of over 1,500 Canadians aged 18 and older. And then we also did focus group interviews with a small sample of vaccinated and unvaccinated individuals who had taken the survey. Okay. So this research was done in 2021, so right smack in the middle of, or at the very beginning of the vaccine, the pandemic, sorry. So in the first paper published in Vaccine, we drew on the focus group data and found that expressions of COVID-19 vaccine hesitancy were most frequently associated with an information surplus or an inability to prioritize information from multiple and often contradictory sources. Additionally, top-down pro-vaccination messaging often triggered significant pushback from the respondents, especially when they perceived the top-down messages as moral shaming or blaming those who are unvaccinated. Okay. In a second paper published in PLOS One, also using the focus group data, we found that under the high uncertainty decision-making environment presented by the COVID-19 pandemic, the factors that most closely relate to COVID-19 vaccine hesitancy included things like values, trust, social environment, personal anecdotes, environmental fluctuation, prior knowledge, perceived risk, and systems of care. So for example, under values, we found that there is a clash between individuals' personal value systems and the public health agency's approach to vaccination, and this contributed to the kinds of hesitancy that were observed. Under perceived risk, this mostly pertained to respondents' perceptions around the risk associated with taking the vaccine, especially negative side effects that were a huge concern among the respondents. And a final example is systems of care. This entailed respondents' concerns around the effect of not being vaccinated and how unvaccinated status might affect their access to public care systems. And so these are kind of what we call the taxonomy of COVID-19 vaccine hesitancy, again, among a general population of Canadians, adults. And finally, in a third paper published in BMC Public Health, we drew on the survey data and found that a deficit in both interpersonal trust and institutional trust was associated with higher levels of vaccine hesitant attitudes. So by interpersonal trust, we mean trust in family, roommates, friends, classmates, coworkers, and acquaintances. And by institutional trust, we mean trust in police, the local government, pharmaceutical companies, the federal government, media, doctors, healthcare system, the World Health Organization, and scientists. So it was actually very interesting that Dr. Cénat's a contextual comment at the beginning about how members of the Black community actually call scientists here at the center for advice on vaccination. This is very much part of the institutional trust component of COVID-19 vaccine. So we found that actually, while both interpersonal trust and institutional trust relate to COVID-19 vaccine hesitancy, institutional trust itself had a much stronger effect on COVID-19 vaccine hesitancy and can be seen as a distinct construct different from interpersonal trust. Okay. Now, what do we know about COVID-19 vaccine hesitancy among immigrants? Well, we know that immigrants are essential workers, and during the pandemic, they remain on the front line, meaning that immigrants were disproportionately vulnerable to contracting COVID-19, and also they were disproportionately vulnerable to secondary effects of COVID-19. So my colleague Edward Ning and I at Statistics Canada looked at mental health and socioeconomic status as secondary effects. Ed also looked at mortality among immigrants that were attributed potentially to COVID-19 and found disproportionate rates of mortality there too for immigrants. But in terms of COVID-19 vaccine hesitancy itself and even vaccine status, we really don't know that much yet about nativity status differences because the data isn't collected according to nativity status. And so that information is actually a big question mark for the moment, okay? And that is where the study that I'm going to be presenting on this morning comes in. So this is a study being led by my colleague Ian Gold at McGill, also with colleagues from Guelph and the University of Western Ontario. The purpose of the study was to investigate foreign-born Canadians' attitudes to COVID-19 vaccines and to develop a trust-based strategy for increasing uptake of vaccines, but also boosters. So public health depends significantly on the population's trust in government institutions, as some of our pilot work had suggested. And a lack of trust leads, among other things, to individuals actually rejecting recommendations for health-related behaviors, including vaccination. So we contracted Environics again to conduct a survey of over 1,500 adult immigrants. These are first-generation individuals, and then also a comparative sample of 500 native-born Canadians. The recruitment was done through Environics sample providers, Dynata and Asking Canadians. And these companies recruit participants from a panel that includes Canadians who have previously opted in to participate in online surveys. So one of the limitations of the research that I'm going to be presenting this morning is that we have a very select sample, meaning individuals who are highly educated, who typically tend to participate in these kinds of online survey panels. Okay, so just kind of keep that in mind as well. Now, in addition to the survey, we are doing qualitative interviews with 100 immigrants who took the survey. And we are following individuals whom we call hard hesitants. So these are individuals who were against taking a vaccine and did not change or intend to change their minds because of conspiratorial ideation. We're also following and doing interviews with what we call soft hesitants. These are individuals who are initially hesitant but did or envisioned taking a vaccine. And then we're doing a small longitudinal qualitative study of 25 individuals from the hard hesitant group, and we interviewed them multiple times over the course of a year, okay? So some examples of the kinds of themes covered in the survey are shown here. I'm not going to present on all of these themes, but I will talk about vaccine status and vaccine hesitancy, and towards the end, talk about the consequences of the pandemic for racialized communities. Okay, so I know there's a lot of numbers. I'm just, for each slide with a ton of numbers, what I'm going to do is give you the take-home message point so that you don't have to scrutinize over all the numbers, okay? So this is just to give you a sense of who we surveyed. We had over 2,000 participants, actually, but this analytical sample is much smaller than that because I omitted a small group of Indigenous participants simply because the sample size was really tiny, and also I was interested in looking at group differences by nativity status, and so the Indigenous population was removed from this current analysis, okay? So the things to take away from this slide here, comparing immigrants to Canadian-born respondents in the survey, are that immigrants tended to be slightly older than the Canadian-born respondents, and there were more women among the Canadian-born sample than the immigrant sample. In terms of where they were living, more of the immigrant population were living in Ontario and BC at the time of the survey. So some of these sociodemographic backgrounds are important, and we'll come back to them later in the presentation. To give you a little bit more sense of who the immigrants are that we sampled, here's information about the duration of residence of the immigrants. What's interesting here is that over 70% of the foreign-born respondents had been in Canada for 21 years or more. Meaning that, again, because of one of the limitations of the study using online panels, is that we are really capturing an immigrant sample that is much more established, right? And therefore also very potentially less vulnerable to the pandemic, because we know from published research that during the pandemic, it was really recent arrivals who are the most affected by COVID-19 in terms of infections, but also secondary effects too, okay? Next, we want to look at the immigrant sample in terms of the world regions where they're coming from. So that's presented here on this next slide. The distribution is mostly from, the respondents are mostly from Asia, Europe, and then other parts of the world. Okay. Now I'm going to share a little bit of information about vaccine status by nativity status. Okay, so what you see here is responses to the question, have you received any vaccines for COVID-19, which is the first line. And then the second question is, what is the most recent COVID-19 vaccine that you have received? And here we're calling it vaccine number because we break it down by the different doses, okay? So the important takeaway point from this slide is that the overwhelming majority of respondents, regardless of nativity status, have been vaccinated by the time of the survey, okay? So 96% of respondents overall took the survey, which is much, much higher than the 81% that was mentioned earlier in terms of the national rate for Canada, okay? Looking then to the vaccine numbers, we also see that there aren't statistically significant differences between immigrants and native-born Canadians in terms of the number of vaccines, right? So most of the participants in our survey had taken a booster already by the time of the survey. And the survey was conducted between May and July 2023, so very recently, okay? So we have very high levels of COVID-19 vaccination amongst our sample, and differences by nativity status are not meaningfully different. Okay, but the picture changes a little bit when we switch to disaggregating the analysis by race, okay? So we actually, in our analysis, we actually have much more fine-grained groups of racial ethnic groups, but for the purposes of the analysis, they were aggregated to create larger subsamples, okay? So when we look at COVID-19 vaccine status by race, we also see similarly a very high level of vaccine uptake, okay, over 90% across all racial groups. But racial differences are much more pronounced when we look at the number of vaccines taken, okay? So the most striking group differences are observed for the boosters, highlighted in the blue text there. 94% of whites had taken at least one booster. This is in comparison to 65% of Blacks, 85% of Asians, and 78% of other races, okay? So this racial difference in boosters could reflect a combination of hesitancy as well as access, because availability of boosters to certain age groups or populations come into play here as well too, okay? And just as a FYI, the subgroups that were grouped into the Asian category are East Asian, South Asian, and Southeast Asian. And then the other category includes Latinos, those of Middle Eastern descent, and individuals with other or unknown racial group categorization. Okay. Then I also did a analysis of vaccine hesitancy by nativity status, okay? And the important thing to remember in all of these subsequent analyses looking at vaccine hesitancy is this is looking at vaccine hesitancy attitudes among those already vaccinated. Okay, so they've somehow, even though they've become and taken and had a vaccine, they still express some vaccine attitudes, at least at the beginning. Okay, so our analytical sample, if you recall, was around 1,984 participants. 84 of those participants did not take a vaccine yet by the time of the survey. So any analysis on vaccine hesitancy is based on the 1,900 individuals who did take the vaccine, okay? So what we see here is that there are no significant group differences in COVID-19 vaccine hesitancy among those who are vaccinated by nativity status. But again, we see that the picture changes if we go to, sorry, it's hard for me to see. If we go to looking at the analysis by race and ethnicity. So here we see that when we look at the question, which of the following best describes when you first got your COVID-19 vaccine, more Black respondents said that they waited until they felt more comfortable with the vaccine before taking it. This is in comparison to only 15% of white respondents, and Asians and other racial groups were somewhere in between, okay? Now, the next question, thinking back, how hesitant were you about a COVID-19 vaccination prior to receiving one? Again, we see stark racial group differences here. So 31% of Black respondents who were already vaccinated said that they were somewhat or extremely hesitant about a COVID-19 vaccination prior to receiving one. And this is really double the percentages for whites who had said that they were also hesitant, and Asians and other races fall somewhere between with 19 and 22% respectively. This next slide shows you some logistic regressions predicting vaccine hesitancy. So the question that I showed previously, where they said they were either somewhat or extremely hesitant prior to receiving the vaccine. The things to highlight from this very busy table is that race is a strong predictor of COVID-19 vaccine hesitancy, but it wasn't always consistent across the different models, okay? Age and sex, however, were the strongest predictors of vaccine hesitancy, and this is really consistent with the literature, where younger age groups tend to be more hesitant than the older age groups, and women are more hesitant than men. Something that could be interesting to the group here is that consistently we also find that compared to Ontario, Quebec residents were less hesitant than in terms of receiving the vaccine. Okay, so what's the takeaway message from this first slide? Well, it is that we don't see any meaningful group differences when we're looking at vaccine status or vaccine hesitancy and attitudes by nativity, okay? But we do see meaningful differences by race and ethnicity. So next, I want to explore COVID impacts on racialized communities. How much time do I have left? Oh, keep going? Okay. I will keep going until I get the message to get yanked off the stage. So this next slide here shows you information on perceptions of COVID-19 impact on the community. So the question that was posed to respondents was, what community do you identify with most? Because we know that, you know, many people may have different affiliations and define their communities based on different social categories, okay? So here you see in the first row, the community identity in terms of race, ethnicity, or national origin, in terms of religion, occupation, and other affiliations, okay? For the whole sample and then by different racial groups. The thing to highlight here is that there's quite a bit of variation across the racial groups regarding how they define their community, although the majority of all races actually define community in terms of race, ethnicity, or national origin. For Black respondents, religion was also an important component of their community identity. And interestingly, for whites, Asians, and other racial groups, occupation was another important component of their community identity. Okay. Looking to the second row of data, the question asks, do you feel that your community has been affected, more affected than others by COVID-19? Okay, so depending on what they said was their community, we would insert that answer into the follow-up question. And here, notice that we're not necessarily putting a positive or negative valence on the impact of the community. We're simply asking, you know, if they felt that their community was more affected by the pandemic than others, okay? And what you see here is also significant racial differences and perceptions of the pandemic's impact on communities. Close to 1/3 of Black respondents said that their community was more affected than others by COVID-19. About 1 in 5 Asians felt that their community was more impacted by COVID-19 than other communities. And in contrast, the proportions of this response for whites and other races were much lower at 13% and 16% respectively. Okay, what about discrimination or perceived discrimination? So this question is drawn from the Statistics Canada rapid surveys. And it asks, since the beginning of the COVID-19 pandemic, have you experienced discrimination or been treated unfairly by others in Canada because of any of the following? And it gives them a long laundry list of reasons, okay? What we see here are significant racial differences in perceptions of discrimination since the pandemic against the individual respondents, okay? With the highest rates shown for Asians at 35%, followed by individuals of other races, and finally by Black respondents. White respondents tended to report that they experienced discrimination much less than the other non-white groups. The bottom panel shows the reasons that the respondents gave for experiencing the interpersonal discrimination. For all of the non-white groups, race or skin color and ethnicity or culture were the top reasons given. For whites, the top reasons given were age and other reasons, so like physical appearance or disability. Okay. Now, if you remember the numbers on this very first line here in terms of the proportion who reported that they individually experienced discrimination, okay? Contrast that with the numbers that you see here on this next slide, where the question asks about not necessarily individual experiences of discrimination or unfair treatment since the pandemic, but the community to which the person belongs to's experience of discrimination. And the proportions increase across the board for all of the, for both Blacks and Asians, but actually decreases for whites and decreases slightly for individuals of other races, okay? So whereas 21% of Black respondents have said they personally experienced discrimination since the pandemic, 31% said that their community experienced discrimination or unfair treatment during the pandemic. Likewise, whereas 35% of Asian respondents said that they personally experienced discrimination, 41% of Asians said that their community experienced discrimination or unfair treatment during the pandemic. And this shouldn't be surprising to any of us in the room, right? Because we know that during the pandemic, there was a 600-fold increase in incidents of racism and hate crimes against Asians in Canada and in the US and around the world more generally, okay? So these numbers are reflecting some of that, okay? And again, some of the top reasons for the discrimination against the community remain roughly the same. So the conclusion from the second analysis is that perceptions of the impact of COVID-19 on communities were much stronger among Blacks and Asians respondents, and perceptions of discrimination against oneself and against one's community were also stronger for Black and Asian respondents. Okay. So what's the kind of takeaway points in general from our analysis? One, despite the presence of COVID-19 vaccine hesitancy, the overwhelming majority of respondents in our sample did end up getting vaccinated anyway. And again, this is attributable likely to the very select nature of our online sample. Among those who were vaccinated, racial group differences in hesitancy were much more pronounced than nativity status differences. But thinking back to kind of what I started my talk a little bit about the experiences of immigrants and, during the COVID-19 pandemic, we still don't know that much in terms of the impacts of economic insecurity and recovery, so the secondary impacts of the pandemic for immigrants and certainly for racial ethnic minorities, because we know that the majority of the immigrants in Canada are composed of racial ethnic minorities, right? We also don't know that much about food insecurity and the possible long-term health consequences of food insecurity during the pandemic. We know that prior to the pandemic, immigrants and especially refugees are prone to food insecurity. And what we don't know is that how much that was exacerbated during the pandemic. So, given my interest in health, we have these questions in our survey. So look forward to future results from that to inform this final question. So thank you, and I welcome your questions at the end.
Thanks, Dr. Vang. The following presentation will be done by Health Canada team on racial disparity in COVID vaccination in Canada. Cette présentation sera animée par Miss Mireille Guay et Nicolas Gilbert. Alors, un peu de background. Nicolas Gilbert est épidémiologiste, spécialisé dans indoor and air quality, exposure assessment, environmental epidemiology, perinatal epidemiology, infectious disease surveillance, and immunization. Donc, ça tombe pile poil dans son rayon d'action. Miss Mireille Guay, she is currently the acting chief of Biostatistics and the Modelling Division at Health Canada. In her previous role at Public Health Agency of Canada, she served as a senior epidemiologist and biostatistician with the Vaccine Coverage and Effectiveness Monitoring Division. And she also conducted research on knowledge, attitude, and belief about vaccination of various population groups, such as parents, pregnant people, and vulnerable population. Je vous invite donc à prendre la parole. Merci.
merci pour la présentation. Juste pour préciser, je suis de l'Agence de la santé publique du Canada. Je suis gestionnaire intérimaire de la section des couvertures vaccinales à l'Agence. Et en fait, donc c'est une équipe de l'Agence de la santé publique du Canada parce que Mireille est maintenant à Santé Canada, mais elle est ici à cause du travail qu'elle a fait avec nous quand elle était à l'Agence. Et donc, voilà. OK. Donc, on a préparé notre présentation en anglais. Donc, on va la faire en anglais, mais à la fin, évidemment, vous devinez sans doute qu'on sera tous deux capables de répondre à des questions dans les deux langues officielles. So we would like to begin by acknowledging that since we are in Ottawa, we are on the traditional unceded territory of the Algonquin Anishinaabe Nation, and we recognize that we all work in different places and that therefore we work in a different traditional Indigenous territory. So, and we have no conflict of interest to declare. We will describe the background behind our project, our objective, our methods, and two major set of analysis we did about for, at least one dose and additional dose of COVID-19 vaccines, and describe sociodemographic and health-related factors associated with lower uptake, discussion and strengths and weaknesses of our studies, and next steps.
That's it.
All right.
Page 10. Page 10.
So, COVID-19 vaccination started in December 2020 in Canada, and at the onset of the vaccination campaign, we at PHAC started to monitor vaccine uptake at the national and provincial territorial levels through the Canadian COVID-19 Vaccination Coverage Surveillance System, or CCV-CSS, to which provinces and territories reported using data from their immunization registries. And during the first 15 months of the campaign, so it's not the pandemic, actually, it's the vaccination campaign, we issued a weekly report that we were posted online. However, this was for the entire population at provincial and territorial level, whereas PHAC aimed at monitoring equity in vaccine uptake between socioeconomic classes, racial and ethnic groups, and Indigenous people, among others. And since registry do not capture the information needed for that, we use surveys for that purpose. PHAC analyzed first data from a special survey, the COVID-19 Vaccination Coverage Survey, or CVCS, and then used the Canadian Community Health Survey, CCHS, to report on vaccination coverage in socioeconomic groups. We issued a first report on equity in vaccine uptake using one collection period of CCHS in October 2021. But it focused only on socioeconomic factors because we didn't have enough, a sufficient sample size among racialized community and Indigenous population. So we continued, as the CCHS continued to acquire data, we ran our analysis and issued a first report on ethnic disparities using 3 collection period of CCHS, but after that, even we continue to refine our analysis, the result of which we will present today. And these analyses were conducted by Mireille, who was then with our team, and since I will let her present her work, and I will come back to present our future work.
Merci. Merci, Nicolas. So, let me just... Okay, so to start with, let's look at the objective. So we wanted to compare COVID-19 vaccination coverage between Indigenous, racialized, and white people in Canada. And we looked at it from two different angles. First, we looked at least one dose of COVID-19 vaccine, and then we also looked at additional doses. Just to clarify what we mean by additional dose, it's defined as any dose received after the completion of a first dose or two-dose vaccine primary series, because some vaccine required 2 doses and other vaccine required only 1 dose to get fully vaccinated. Those additional doses are mostly booster doses, but they may also include additional doses given for other reasons, like for immunocompromised individual or for travel purposes. And the information that we have does not permit to differentiate between a booster dose or an additional dose received for another reason. So that's why we're calling them additional doses. Another thing that we are going to look at today is sociodemographic and health-related factors associated with lower uptake of additional doses. And finally, we'll look at COVID-19 vaccination coverage over time. I don't think we have that. We didn't have time to put it in the presentation. And then this is all done using Statistics Canada Canadian Community Health Survey, CCHS data, that was collected between June 1st, 2021 and the end of June 2022. Let's start with some background about the CCHS. So it is a nationally representative survey conducted by StatsCan, and it collects information on health status, healthcare utilization. Ah, j'ai oublié de... Oui, c'est vrai. C'est bon. Healthcare utilization and health determinants among Canadians. This is a voluntary survey. It has multiple collection periods throughout the year, and they also, since COVID-19 pandemic started, they decided to release the information every single collection period to have timely release and make it accessible to users. So the survey design is cross-sectional. It targets Canadians, or I should say, people residing in the 10 provinces and 3 territories that are aged 12 years and older. And there are a few exceptions. So full-time members of the Canadian Forces, children in foster care, people in institution, those on reserve. And then this large sample size of the CCHS, and I'll talk about the sample size later on, gives us enough power to look at a small population group. So data collection, it was mostly done through computer-assisted telephone interview with trained interviewers. It's about a 50-minute interview. And starting in 2022, StatsCan implemented electronic questionnaire. So most respondents would respond through the electronic questionnaire, but they would do follow-up phone interviews for follow-up for those that did not respond to the electronic questionnaire. So the survey was administered in English and French, and if the respondent did not speak English or French, they attempted to have the interview completed with an interviewer that was fluent in the respondent language. Just a word regarding the exclusion, they represent less than 3% of the Canadian population, so it covers more than 96% of the population. And finally, StatsCan provide weighting, sample weights that are adjusted for non-response and calibrated for age, sex, and geography. So this gives us reliable provincial and national estimates. So I'm good. Okay, so about CCHS, in September 2020, a module with questions about experiences related to the pandemic, along with questions on COVID-19 vaccination intent, were introduced. And in March 2021, they added a question on COVID-19 vaccination uptake. So we're looking at data collected between June 1st 2021 and the end of June 2022. We restricted it to adults, so those 18 years and older living in the 10 provinces. And the reason why we did this is that all adults became eligible for COVID-19 vaccination towards May in 2021. So we wanted to have, like in the survey, only people that were eligible for vaccination. And adolescents, although they are in CCHS, were not eligible for vaccination during the first collection period. And also because of small sample sizes in the territories, we are not able to look at that population until we get a 2-year collection cycle on CCHS. Okay, so just a quick look at the questions that were asked in the CCHS survey. So there was a question on vaccination status for to look at least one dose. So they ask respondents if they have been vaccinated against COVID-19, and they would respond yes with at least one dose or no. And this was used to derive a binary outcome for vaccination status. And there were only 2.4% of non-respondents which were removed from the analysis. And for vaccination status for additional doses, we had a question about how many doses of the vaccine were needed to complete the primary series, and then we also use how many doses they have received so far to look at additional doses. For Indigenous identity, so they were asked about, are you an Aboriginal person that is First Nation, Métis, or Inuk? And then they could mark all that apply. So that's what we use to derive our Indigenous status variable. And in terms of population group, so they were asking about racial or cultural group, and the list that you see there is the different choices that they had, and they could also select other and write or give their answer, and so more than one population group could be selected there. For these questions, we derive a population group variable with 8 categories. So all the groups that we could have enough sample size to look at, off-reserve First Nation, and because StatScan does not collect data on reserve. So First Nation in this survey is always off-reserve First Nation. We also have Métis, Black, Arab, Chinese, South Asian, and other category, and white. So all the multiple and the identities or the groups that were too small to report are combined into the other or unknown group. Okay, the CCHS also collects several sociodemographic and health-related factors. So the ones that we looked at is region of residence, gender, age group, education, Indigenous or racial identity, dwelling ownership status. So we use dwelling ownership status as a proxy for household income because household income is not available. It is not collected in the questionnaire, but it's obtained through linkage with tax files, and this linkage is performed on an annual basis. So we didn't have that available for collection periods only. So we also looked at mother tongue, immigration status, presence of children in the household, employment status, and self-perceived mental health. So here you can see just a timeline of the CCHS collection period that we use for this analysis. So starting in June 2021, and then moving on through 3 collection period in 2021, the collection period 3, ending early February 2022. So just to give you a timing, so as I said, most adults were eligible to receive at least one dose of a COVID-19 vaccine in May 2021, and then by November 2021, they were eligible. Pfizer and Moderna vaccine were authorized in Canada, and by the end of January, adults in Canada were eligible to receive a booster dose. Okay, so moving on. Let's look at the results for at least windows in racialized and Indigenous population. So, okay. So we looked at uptake for at least windows. We didn't look at primary series completed because we wanted to look at inequalities in vaccination coverage and not effectiveness. And also because there are various definitions of fully vaccinated in the Canadian provinces. It varied from province to province in terms of number of doses requirements by vaccine product. And there was also delayed eligibility for a second dose of COVID booster, a second dose of COVID vaccine among younger adults. And there was also this delayed sort of second dose interval that was recommended at some point. So first we looked at some descriptive statistics to compare people with at least windows in Indigenous group and different population groups. Because of small sample size, we could not look at Inuit. And then we also looked at a second step. We looked at multiple logistic regression models. So we adjusted for region of residence, gender, age, education, and collection period. So we just adjusted for confounders, so factors associated with the outcome of vaccination status and the exposure, which is population group, but did not adjust for any variable that could be thought to be in the causal pathway between population group and vaccination status. So just a note, so we wanted to adjust for time, that's why we included collection period in the model, and then region of residence is to account for differences in coverage across the province and also differences in the rollout of the different vaccine that varied from province to province. Okay. Let me see. So moving on to this. So in terms of sample size, the final sample size is just under 6,500. And then response rate was 31%. And then overall, the percent of unvaccinated was 6%. If we look at vaccination coverage, if we compare, here is a comparison of vaccination coverage from CCHS and what we got from our surveillance system, data from registries from province and territories. So for the complete period, it's very similar. We got 94% of vaccination coverage for CCHS and 92% from the surveillance system. So there's just a small gap that could be just explained by differences in the respondents. Let me see. Okay, so just to give you an idea of the sample sizes for the different population groups. So we had, most groups were between 1,000 and 2,000 respondents for the different population group. And of course, a white group is overrepresented in the Canadian population and in the sample. So it's even though we have a large sample size, it's still small population groups. So in the end, we looked, coverage for at least windows was significantly lower among younger age group. As we saw before, males had significantly lower coverage. Those with lower education, residents of the prairies, BC and Ontario, as compared to residents of the Atlantic region, and off-reserve First Nation and Black individual had lower coverage than white individual. And we also noted that coverage was significantly higher among South Asian individual when compared to white. Which slide am I on? So, yes, so This is looking at the logistic regression model, so odds of being unvaccinated versus having received at least one dose by population group. And we compare to the reference group is white individual. So we see that compared to white individual, the odds were 1.8 times greater in off-reserve First Nation people, and also significantly greater odds at 1.7 in Black people. And then we also see the South Asian people having lower odds of being unvaccinated. So I'm done. So looking at additional doses. So for additional doses, we looked at collection periods of 2022 when everyone was eligible to receive at least one booster dose. So for this part of the analysis, our sample size is 32,000 respondents. The response rate was higher in 2022 at 45%. Okay, and looking at, let me see, yes, at additional doses coverage. So overall, it was at 62% between February and June 2022. So that's at least one additional dose, and 5% of unvaccinated individuals. Okay. So we move on a little faster here. When we break down additional dose coverage by race or Indigenous identity, we can see that there was significantly lower coverage among Black people at 33% and Arab individual at 34% when we compare them to white individuals. Okay, and this, and the next slide shows association between additional dose uptake and some socio-demographic factors. So, and those odds ratios are adjusted for a list of factors. So looking at province of residence, you can see that Alberta had, so this is odds of not having received at least one additional dose. So Alberta residents had higher odds of not having received at least one additional dose. Again, we saw that age group was a significant factor. So additional dose coverage was significantly lower in younger age group. There was a significant effect of gender, again, education, where lower education was associated with lower coverage, and also significant association with dwelling ownership, which is a proxy for, we use it as a proxy for income. And then those with young children in the household also had lower coverage. That's the slide. Yeah, that's a slide for gender. Okay, looking at socio-demographic factor again, and then we have here race and ethnicity and Indigenous identity. We see the same association that we noted before. So even adjusted for socio-demographic factor, we still have lower or higher, I would say, non-vaccination or uptake of additional dose among Black and Arab communities, and then Chinese population here shows as being having a higher coverage. Can we move? Yes. It's hard to see. So the strength of this analysis, so it's a population-based study, so findings are nationally representative, so we can make inferences about the population of Canada. It's a sample size large enough, so we have large enough power to detect differences. And this is a general health survey, so it's not a vaccination survey. So it is not perceived as a vaccination survey, so there's less risk of selection bias there for participants. In terms of limitation, so it's self-reported data. It's susceptible to bias such as social desirability bias and recall bias, although this was done pretty close to when they got vaccinated. And people would recall if they were vaccinated for COVID. However, there was a low response rate during at least the first part of the pandemic in 2021. So CCHS used to have a response rate above 60%, and it dropped to 30% at least in 2021, and it increased in 2022. But we cannot rule out non-response bias there. And unfortunately, we don't have data from territories or other smaller subgroups. Okay, so in terms of, as a previous speaker mentioned, there are some common findings that are that we can see across different studies. So lower vaccination coverage in offers of First Nation people compared to white people. This could be explained by some provincial policies that delayed access to vaccination among First Nation people in cities as compared to those on reserve, and also mistrust in vaccine and the healthcare system. There was also, we noted lower coverage for at least one additional dose in Black people compared to white. And again, as we noted before, there's higher vaccine hesitancy associated with distrust in government and the medical profession among Black people that could explain some of this lower vaccination coverage. We noted as well higher coverage for South Asian people, and then those trends were also noted in a US study, as well as for influenza vaccine in Canada using CCHS data collected prior to the pandemic. However, we don't have information in the survey to understand the factors contributing to lower uptake among those groups. And having further research would also help to contribute to target public health messaging and programs to better serve those communities. So in conclusion, I'll just highlight a couple of things just so we, in terms of, we noted that we had inequalities in coverage for additional doses, especially among Black and Arab individuals that had lower coverage, and then higher coverage for Asian individuals. And then in interest of time, Nicolas, you want to come and talk about the next steps?
Yes. So, to inform the equitable delivery of vaccination, PHAC conducts two distinct and complementary streams of work. So, what we just talked about, the analysis of equity in vaccine uptake through surveys of the entire population and comparisons between population groups. This is what we can do ourselves, and in addition to that, we fund surveys of vaccine uptake and hesitancy conducted by partners well-rooted in equity-seeking populations, such as the center that is hosting us today. So for this, we fully acknowledge that such groups are better placed to understand what is going on and what are the roots of the inequalities we can observe but not explain with our population surveys. So for more information, the ethnicity component of our analysis have been published, and you have the reference here. It was late in 2023. And well, I couldn't, we couldn't not end by thanking all those who did that work. Of course, Mireille led the analysis, but some of our colleagues within PHAC contributed to the analysis or the literature review supporting it. Also, our colleagues of Statistics Canada were very instrumental in help in these analyses, and also some external experts, including Dr. F. Dubé here, who provide us lots of advice in initially designing the question, because the module we influence the vaccination module of CCHS and to interpreting the results. So thank you. In addition, we benefited from advice from Dr. Shannon McDonald from the University of Alberta and Michelle Dreger from the University of Manitoba. So if you have, there will be a question period, but if you take home the survey and have an additional question or discussion point, you can reach out through the generic email of our team. Thank you.
Thank you. Et merci beaucoup, présentateurs, présentatrices. To move forward very quickly, I would like to open the floor, but before, please give upload to all our presenters. So we are running out of the time. If it's possible to have very few questions to presenters, to Dr. Vang and to public health team, Public Health and Health Canada, right? So the mic is in the middle, mais si votre voix porte, vous pouvez rester à votre place et poser la question aussi. N'hésitez pas surtout. Première question, non? Derrière? Pas de questions? Il devrait y en avoir, là. Oui.
Hello, thank you so much. I'm Peter Newman from University of Toronto, and thanks for both talks. It's really great to have access to all this data and information. I just wondered, I understand some of this is your impressions, and for people that are more want to rely on the data to say things, you can say how much you wish to interpret or not. I just wondered in terms of the really helpful Health Canada data in terms of the breakdown in terms of race, ethnicity. So obviously there's benefits of a representative sample, but does Health Canada also do things of over-sampling certain subpopulations to know, when you know that there's going to be challenges potentially? I just wondered, is that available? Or I realize you don't make the policy for Health Canada, but I just wondered. And I also wondered for both presenters, to what extent do you think, at least in the initial rounds of the surveys, that people may be hesitant to discuss their vaccination status, and that it's even more people who didn't receive the vaccine are not responding to the survey because they don't trust a vaccine, they don't trust public health, they don't trust a survey researcher calling them. So I wondered if the things might be higher, actually.
I can get started. So in terms of the CCHS, it's a general health survey, so it doesn't really mention vaccination at the outstart. So it's just a very small module towards the end. So it wouldn't overly influence, I think. And especially if it's like self-administered electronic questionnaire, it's, I guess, less prone to bias than when you actually answer to an interviewer. So that would definitely help. The part about other Health Canada research, so there are other, maybe Nicolas can speak about it, but there are other, so we leverage the StatsCan CCHS survey, so we did not design it, although we helped developing the COVID-19 module content, but there are other targeted surveys that are led by the Public Health Agency to specific groups.
Yes. Yes, I must say that this survey, as you can see, has a very large sample size, and this is what allowed us in a population survey to look at ethnicity. PHAC does conduct a vaccination coverage surveys in the population survey of the, probability surveys of the entire population of our own, such as the Childhood National Immunization Coverage Survey, but we never had enough, by that kind of sampling, we never had enough people by ethnic group to do that kind of analysis. So CCHS is kind of a unique opportunity. Having a module on COVID-19 vaccination in CCHS was a unique opportunity for us to do that kind of analysis, which we could because of the large sample size. The only other way to do that kind of to look at what is going on in the ethnic groups is to conduct targeted studies that we fund, and some part are done by the center here, but these allow to explain what is going on in this community, but not to compare. So you cannot determine the existence of inequalities unless you conduct the same and ask the same question across communities. So these two approaches are complementary and provide different pieces of the puzzle.
I think that certainly there is always the chance that we're going to be missing those individuals who are really what we call hard hesitants, right? And who are skeptical of researchers and have a lot of institutional mistrust. I was reassured actually by the second presentation that showed only with this nationally representative sample that only 6% of their respondents were unvaccinated compared to our 4%. So that helps me to have a little bit more confidence that despite the selection bias, we were able to get quite a decent sample of individuals reflecting the general population in many ways. I think the beauty of a kind of mixed method study design the way that we have is that we're able to also ask qualitative questions, and especially the kind of longitudinal follow-up of individuals over time to assess how their attitudes and vaccine hesitancy attitudes have changed over the course of the period. And so what's interesting is that in some of the qualitative interviews, we are finding folks with attitudes whom we would call conspiratorial. So although we may be missing the extreme folks, we are catching some of the individuals who exhibit a lot of mistrust and against the government, against scientists and whatnot. And so that's shedding light on the kind of not necessarily ideology, but the worldviews of these folks who are really hesitant. Yeah, thank you.
Thanks. Those are very, very helpful answers. Thank you.
Question suivante. Oui.
Hello. Thank you, all three of you, for your presentations. My name is Raj Hoti, and I'm a recent Master's of Public Health graduate. So I'm very interested in learning more about vaccines and racialized populations. I was really curious about Dr. Vang's, your comment about kind of the difference in data between individual perceptions of discrimination and community levels of discrimination, and how there seemed to be a little bit more relation about community discrimination. And I was wondering, like, you mentioned the anti-Asian sort of sentiment at the time, but I was wondering if there was any more specific questions into kind of parsing together maybe why that difference existed. And then for the Health Canada and PHAC team, I noticed that there was higher vaccination among South Asians, which I found quite curious. I was wondering how you could pair the two with experiencing like more discrimination, but then this population seemingly having more being more vaccinated.
Thank you for the really great question. The short answer is that we don't have additional questions in the survey that would help us to deduce the difference between perceived individual discrimination and community discrimination. Potentially, when we look at the reasons, we see that they're really similar, right? So the kinds of reasons given for oneself experiencing discrimination and one's community are pretty much around race, ethnicity, national origin. And so I also suspect that, you know, when we look at the social psychology literature, there might, you know, people tend to remember big events when they're, especially on a survey, and they're thinking back to the pandemic and over the course of a year or 5 years if they experienced discrimination. So we know that an individual will remember a big event like being spat on the street, for instance. But will they recall, not receiving service because they're wearing a mask? Probably not, right? So it's those differences. But when you look on the news, especially in many of the Asian communities, there was a lot of media coverage, and within the communities themselves, there was a lot of information passing through networks, individual networks, about anti-Asian racism during the pandemic. I mean, I was living in Canada at the time, but my mother, called me and said, "Don't go outside because, you're going to get, spat on or somebody's going to do something to you." And to this day, she warns us not to go walking in the park because she's afraid that something's going to happen. So, the kinds of community messaging and the community stories that get passed around are probably what's influencing the gap between individual perceptions of discrimination and one's community. And I think the differences between the Black respondents and white respondents are also different too, right? So for the Asian respondents, it's about direct attacks and about that kind of concern. For the Black respondents, the kinds of discrimination against their community may have to do with attacks, but it may be more broader than that because of what was happening around the pandemic and lack of access to some of the issues, and the kinds of mistrust that exist in the Black community historically against the medical profession and whatnot, right? And so while both groups had higher elevated rates of individual perceptions of discrimination and community discrimination, I just want to caution that the reasons behind that may not necessarily overlap. Yeah.
Thank you. In terms of our data, so South Asian community had higher vaccination coverage as compared to white individual, and then it's similar findings that we at least see in the U.S. So it aligns with what has been seen in other countries, but there are different factors to take into account. So there's taking the vaccine, and then so experiencing discrimination at a community perspective or personal is something, and hesitancy. So you can still get vaccinated, but delay it. So it would be hesitant. And again, like some communities were facing barriers. So you might not be hesitant, but you're facing some barriers to get vaccinated, either getting some childcare while you get vaccinated, or it's like commute there, or the vaccination clinic not being open when you're available, that sort of thing. So there are tons of factors that could play a role in different vaccination coverage in communities. So it's hard to say which factors are contributing to South Asian, but it looks like it's something that is seen in other countries and even also for other vaccines than COVID-19.
Absolutely, and I guess as Dr. Wang's research suggested, that the survey participants tended to be racialized populations that were, or like immigrants who were more stabilized and had been here for a longer period of time, so that could also maybe be a factor. But thank you both for your very insightful answers.
Thank you.
Il y aurait une dernière question en français? Question? Bon, donc on va poursuivre. Je crois qu'on peut commencer à prendre notre pause.